So we're doing a colonoscopy to assess a chronic inflammatory bowel disease with an atypical lesion at the left flexure that we'll go check out in a moment. But right now, we've just reached the cecum and we wanted to do a global assessment. The first thing that really stands out is the inflammatory aspect of this colonoscopy. So it's true that in such an inflamed environment, it's going to be very, very difficult to be precise with the endoscopic diagnosis. Ideally, we should review this again, even though that won't prevent us from removing the concerning lesion or taking macrobiopsies. We'll go see. But we'll probably need to come back and see this patient after intensifying treatment if possible, and if we can achieve a bit better healing so we can move forward with less inflammatory components. Now I'm trying to enter the valve underwater. It must be a bit closed due to the inflammation. The cap is helping us. I'm going to try to straighten out the scope as much as possible to get a smoother movement. I'm not sure I'll be able to push through without looping again. No, that's not possible, so we'll start over. Aim for the valve here, there we go, go left. No, it's a bit averted. We'll be able to get in with the GDO. That really helps a lot, and there it opens up, so it's much less difficult to get in with a bit of left movement usually, and some water to expand it and see it properly. I'm trying to straighten out to go a little further into the valve, but it's not easy. We're at the end of the tube there anyway. It's better to spot it beforehand if possible. We saw the little labial commissure of the valve. I'd like to recover some tube to be a bit more responsive, but it's not simple. There, now I'll have a bit of leverage and can go a bit further. It's not necessarily very useful to go much further. My tube really doesn't want to extend anymore. Again, there are lesions everywhere. I don't think we can go much further than this. That wasn't our goal anyway. The goal is the left flexure, but I still needed to do a full assessment. So in any case, we clearly saw the ileocecal valve. It's completely averted. Now let's track the lesions. As is often the case, there's cecal involvement with an appendix that all around has a very inflamed mucosa with fibrin deposits everywhere, and the crypts are very enlarged. Here we even have an appendix that's downright villous, very reactive. We'll take a sample to be sure this is all just inflammation and there's no dysplasia at the appendiceal level. But it's very difficult to distinguish between a hyperplastic reactive inflammatory appearance and an adenomatous one. So the first lesion isn't really a lesion in the strict sense. My impression is that it's mainly inflammatory, much redder in white light, much greener in narrow band imaging. For me, the mucosa is the same as the adjacent mucosa. But since it's inflamed and scarred, the mucosal and particulate reliefs are much more visible. There's a kind of increase in the size and vessels. I take the enteroid and the vessels and mucosal relief. So for me, this is purely inflammatory. It doesn't correspond to a neoplastic lesion. Still, to be sure, I'll take a sample from this expert area of the ileum. And in my opinion, it's an area that's either inflamed now or in the process of healing. Let's turn off the narrow band imaging. I'm right at the right angle, so it's not easy. Can you help me, Ben? Or it's not really pinching much at all. It's probably a little bit tense underneath the surface. Here, we are not at all dealing with a classic polyp on normal, healthy mucosa. So sometimes if the submucosa is quite fibrous, for example, we can't really grasp it effectively to take it with the cold snare technique. Count to 2 slowly, then
count all.
2, right angle, that's good. So here we are, we've found the lesion that's causing concern and for which an MDT, multidisciplinary team meeting, has validated the approach. So it's right in front of us, down there. It's indeed a slightly lighter area, which, as you'll see, looks like a serrated epithelial change. First, let's quickly talk about the tattoo, because someone put a tattoo here to help us, which is very nice and helpful in a situation like this. However, you shouldn't do it upstream of the lesion, because peristalsis tends to push the ink down, so it moves. Look, I'll show you where the injection was done. You can see it clearly here. And look, as we go down, 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 the ink has spread all the way to here. So up to this point, we'll have ink in the submucosa. So when you want to tattoo, do it on the wall opposite the lesion if possible, and downstream, making sure to note in the report that it was done downstream. This way, peristalsis and the movement of the colon push the ink downward so it doesn't interfere with resection. Because if the ink ends up under the lesion, it will make things difficult. Now, to characterize this lesion, you can see it even better with chromendoscopy. It's an area that's much lighter than the surrounding mucosa. I'll show you. Let's go underwater. It usually stands out underwater. There, you can see it at the bottom. Let's remove the air. There it is at the bottom. Then we'll resect it to reassure everyone about the absence of... You see, there it is at the bottom, a much lighter area than the surrounding mucosa with very clear borders. Look to the right, you can see where the lighter area stops. The surface relief is generally quite normal, but we don't really see round crypts anymore. The crypts are more elongated, a bit more cerebriform, resembling those of an adenoma, but there are no visible vessels at all, or they're so fine you can barely see them. This gives the area a very pale, cloud-like appearance, unlike a typical serrated lesion, with no black dots inside, none at all, and no visible vessels, or they're so fine you can barely see them. If you look at an inflammatory area opposite, you can see dark structures surrounding each mucosal crypt, so it's well vascularized there. In the serrated epithelial change, the so-called festooned epithelial remodeling, you get this cloud-like appearance with a surface relief that's not made up of normal round colonic crypts, but more like a cerebriform adenoma. Still, there are no vessels and no black dots at the bottom of the crypts, unlike a classic serrated lesion. These lesions are not associated with a higher risk of colon cancer, according to recent studies, though we still need to learn more about them. So there was a multidisciplinary meeting, the lesion was presented, etc. And now we're going to resect it to confirm that it is indeed a serrated epithelial remodeling lesion, but we're not really worried about it, and we don't expect to find dysplasia, which is good news for this patient, since it's the only lesion like this that he has. So we'll start the resection now.
When you say not higher, you mean not higher than serrated lesions. It's the same, right?
Not higher than a patient who doesn't have this type of lesion.
All right.
So, it's not a risk factor for cancer in these cases for now. It still needs to be confirmed in larger series. The precise description of these lesions is still quite new, but in any case, based on their appearance, once again, we expect something non-neoplastic, but, well, with these cases, you have to be careful. You can really make a mistake. That's why we still resect them and need confirmation. Go ahead, inject slowly, then all the way. So here it is. The lesion, we can see it clearly. Look, the submucosa is not normal at all because it's white, it's translucent. Well, it starts at the posterior pole. Oh, but I think it's not plugged in. I was waiting for you.
Sorry, so here you're starting at the posterior pole?
Exactly, that'll be my exit at the end.
You're going to make a tunnel, right?
The space isn't wide enough to make a tunnel, in my opinion. There are other strategies. We're not saying this is the only possible one, but I'm going to use traction, okay? Probably either adaptive traction if it were really large, but here it's not that big of an area, so I think simple traction will do. I don't think we'll lose much tension before the end, so it should work with standard traction. Okay, so for the back, we're going to get there.
Do you think you're going to have some light in the submucosa there, or...
How do you...
Do you have light in the submucosa?
I don't think so. I think we got lucky and it stopped. On the other hand, we're going to have this little ulceration here that's really going to make it hard for us to get in. It's not easy to find the right plane when it's stuck together like this.
Yeah, and with the ulcerations, you get that red fiber just underneath.
Yeah. Am I actually able to successfully find a plane? It's not an easy task at all here. It's really quite difficult indeed. Let's go.
And you don't take the needle again when you can't get through?
It's not always easy with the needle in these very inflamed areas, paradoxically, because you tend to go right through the tissue. So sometimes I prefer to start gently, just making a tiny cut with the knife, to get through the mucosa. But you really need to have done a few of these to feel comfortable with it. Honestly, this isn't something I'd recommend for everyone. This is not the kind of dissection you should start with. Inflammatory disease. The submucosa is very particular. The inflammation is severe. Recognizing the lesion and the diagnostic aspect is complex. You really need to be trained and have seen a few cases. So don't start with this, or you'll get discouraged from doing dissections. There are much simpler cases to learn and understand strategies, so this is definitely not urgent. Maybe we won't need traction, we'll see. If things go well, we can save a few clips. But in the vast majority of cases, traction will make your life easier. So when you're not a beginner, because it's not a good indication for beginners, as we've said, but if you're already a bit experienced but not yet advanced, traction will help you open up this plane that doesn't want to open. Let's switch to therapeutic mode, please. This will allow me to, you can see it's very, very severe in the submucosa.
There you go.
And so I'll be able to activate my pump. Could you lower the flow rate, please, Oxen? We can activate the pump with the finger, maybe a bit too much, yeah. And so we have a constant flow that pushes the lesion back a bit. That's the other alternative.
What, you use it with your finger? You have the finger control for it?
This allows me to keep cutting while the water flow is running. For example, Timothy and others are able to work with both feet at the same time, balancing. You should know that now most suppliers are able to provide finger control for the pump, so basically we can save a foot for those of us who aren't as skilled manually as Timothy. You have to find tricks, manual tricks with your feet, that's all. Let's get back under the water. We'll see better. Right now, my position for the incision on the left isn't great, so we'll go gradually. There are quite a few bubbles coming up. It's very, very, very fatty, as you can see. That's not surprising in the inflammatory process of Crohn's with sclerolipomatosis. It's rare, but you find a lot more fat. And here it's very impressive for a left colon. It's as much fat as you usually see in the right colon, like around an oil ball.
That's clear.
There, it just stopped, quite suddenly. A small, delicate vessel, barely visible. Extreme caution is absolutely essential when navigating through those intricate, fatty bundles of tissue. I must admit, I went a bit too fast there. Perhaps a little overzealous, but I will certainly be more careful from now on.
All right, we'll finish the incision here. It'll be easier.
We will meticulously capture a few additional clips, ensuring they clearly and precisely delineate the entire area of interest. This careful marking is crucial so that if any unexpected surprises or anomalies arise during the procedure, they will be much easier to locate and address promptly. No, I must emphasize that I am not applying any significant traction or pulling force on this particular section. The primary obstruction and challenge here are the numerous small bubbles that are unfortunately obscuring our view and making precise manipulation difficult. Now, with these adjustments, we can observe the field of operation with significantly improved clarity, and consequently, we feel much less disoriented or lost within the anatomical landscape. You can clearly perceive that by gradually and carefully advancing closer to the underlying muscle tissue, our sense of orientation improves dramatically compared to our initial starting point. Furthermore, there is noticeably less adipose tissue or fat present in this deeper region. The more substantial and problematic accumulation of fat is predominantly located just beneath the mucosal layer, which is a more superficial structure. Therefore, the strategic decision to move progressively closer to the muscle is consistently a highly advantageous approach, even if it might initially feel a little daunting or intimidating. This deliberate proximity to the muscle significantly enhances the precision and accuracy of our work, leading to a more successful and controlled outcome.
Here you have gravity that's very, very favorable.
I'm not sure. You see, the hood doesn't fall completely. On the contrary, I think it tends to fall back a bit, you see. It drops over there at the back. So yes, it's a gravity that's not catastrophic. The tricky part is the end here because it kind of flips over itself a bit. So in these cases, you have to go for the edge, the border of the landing, because that's the only place where you can see where you actually need to exit. Because underneath you don't tend to see it since there's a sort of lesion fold, you see. Anyway, that's it, but here it's going to work. But when you can't see the exit properly, always go for the edge, the border of the landing, because there you have information about what's left to cut and where you need to exit to find the light again. So that helps a lot. And you see, I can't keep my water. If we had unfavorable gravity, we'd have water all the time, but here it leaks into the coloboma as soon as I put it in.
It's a bit like we're inside the coloboma.
Further into the coloboma, I don't know if it's to the right or what, but it's a bit like we're vertical, and I constantly have little bubbles that come and bother it that get into the field of view. So watch out for the little bubbles that appear during the underwater cure phases. We'll see if I really put it underwater. Let's try. There we go. Well, despite everything, you'll see bubbles appear. Now this one is from the handpiece, from the pump. You're right in the middle, but still there are others that appear. The bubbles here, it's okay, it's not a lot, and they're linked to the electrolysis of the water, so it's hydrogen and oxygen. And that's because if you've seen the publication from our Japanese colleagues, well, it explodes. So if there's a rather large pocket that starts to get trapped in your cap, you need to make sure to aspirate it well and not try to pop it with the tip of the knife, otherwise it moves well.
Electrolysis of water happens because you're passing an electric current through it.
Exactly. You see, every time we cut, even though the knife is in the aqueous phase, there are little bubbles that appear at the tip. You see, like here, for example. Well, that's electrolysis. It's not a big deal when it's very small. You don't even see the explosion. But if you get a little contact there while pulling back, if you have a slightly larger pocket that forms, again, go check out the article by our Japanese colleagues about gas explosions. The image is actually quite impressive.
We'll put it in the comments of the video.
Consider the link, for example, as a prime illustration of this particular phenomenon. There you go. You can clearly observe when we meticulously tighten it once more, it unfortunately penetrated far too deeply, actually, and consequently ended up emerging from the posterior side, precisely because, once again, the delicate lesion itself folds back upon its own structure. It is indeed quite challenging and not at all straightforward to successfully complete this intricate procedure. That serves as an excellent and very clear example. You can distinctly see that I am not directly on the main vessel. You can perceive its rhythmic pulsing very clearly and unmistakably. But since its vital flow originates from a lower position, I possess the ability to effectively cut it by applying gentle yet firm pressure directly onto the underlying muscle tissue. If I were to cease this pressure, even for a moment, it would inevitably begin to bleed profusely, and if I carefully maneuver my instrument here, there, I will deliberately crush it, and as a direct and immediate result, there will be a significantly reduced amount of bleeding, a fact that you can observe with remarkable clarity. So, is that an optimal outcome? Not entirely, not quite. And oh, look at that little bunny there. Well, he most likely did not appreciate or enjoy what we just performed in that area. There, I will carefully go back and thoroughly check from this specific vantage point. That is precisely where I had the most advantageous and unobstructed view. And then I will meticulously finish by truly aiming for the very edge of the lesion itself to fully and completely open it up, ensuring I know precisely where I am coming out, going in deeply, but always knowing with certainty that we will emerge here, there, with some truly beautiful and informative images. We will diligently stop all the minor bleeds to maintain a perfectly clean and unobstructed image. There we go. That's much better. So here, in this particular area, I believe it is quite easy to inadvertently go too deep. So I will carefully go back over the top to truly establish my precise edge here, my absolute limit for this procedure. The other small, somewhat concerning vessel that is causing us a bit of apprehension, it is coming. It is very often embedded within a sweep of fatty tissue, these vessels, especially when the condition is inflammatory in nature. It is crucial not to penetrate too deeply. Instead, really try to carefully come back up to the very edge over there. I know, it's a delicate balance.
It wasn't a matter of just 5 minutes. My intention was to meticulously tighten and precisely narrow the very end of the creo, ensuring a refined and perfectly sculpted finish. This required careful consideration and a deliberate approach to achieve the desired aesthetic and functional outcome for the creo's terminal section. Rechargeable, you know.
There you go, because we even went a little bit too far. Our actual limit is actually a little bit higher than we initially thought, so we'll go and take a closer look at it. There you go, yeah. It's a bit, you see, even though we diligently try to always catch the very edge, we tend to go a little bit too deep and consequently get caught out because of that significant amount of fat that's located just under the surface, and that really, really thickens the mucosa, and now we are definitely going to feel it.
The glasses, if you would, please.
The small ones, we had a 6 millimeter, and that was not enough. We probably did not reach the submucosa everywhere. There you go. The retraction always seems a bit more significant at the end. As I was saying, it retracts even more in the fibrosis. And now to close up, I'm going to make 2 more incisions. Well, at the same time, we mark the area in case there are any issues. If we ever have a surprise in pathology, well, we know where it is.
Why are you closing up there?
Well, because I want to mark the area, but it's mostly so I don't leave him with a wound like that, which would have to scar over on its own. Can I have a clip, please? There you go. Thank you very much. After that, you absolutely shouldn't close up the colonic fold too much, so please try to be quite moderate and careful with the colonic fold itself. It's generally much better to close from the very top to the very bottom. It's a significantly more logical and intuitive approach for the colic folds compared to going from the right side to the left side, as one might do in the stomach. You can carefully open it, and then in that particular manner, you won't really reduce the overall size of the lumen if we manage to execute it properly. There, perhaps I won't be able to get it all in one single attempt. We might have to perform an intermediate step anyway. Just close it very gently and precisely. Ah, okay. Let's carefully take this. There. It's extremely rigid and unyielding compared to a normal, healthy wall. Close it, clamp it securely. There we go. Let's carefully bring it together. There, perhaps in 2 distinct steps, I sincerely hope, but I'm not entirely sure. It's pretty substantially big. It's really quite relaxed though, because I might just manage it, but I'm not absolutely certain. Let's approach this more like an intricate origami technique. A first delicate layer in the muscle, and then gradually bring it all together, much like the traditional Japanese origami technique. Close it, not great, reopen it, close it again, clamp it firmly, there, less ambitious, that's perfectly okay.
Close, then clamp.
Very good, there we go, it goes through quite nicely and smoothly, just as intended.
No.
Let's go. My main goal was really to reduce the surface area so that it heals a bit faster. When it comes to our dissections, healing always starts from the center, so the greater the distance from the edge, the longer it takes to return to normal. So the aim is to reduce the size of the surface so that healing takes a bit less time and is a bit less prone to contraction, hoping that it does not reduce the lumen too much. For a reduction of less than 50% of the circumference, the stenosis rate is close to 0. Okay, here comes a little pulse.
Do we have any data on whether a dissection causes flare-ups later on?
Flare-ups? I don't think so. I'm not a specialist on the subject, but I don't think it's been described. There are now quite a few papers on dissection in lesions of chronic inflammatory diseases. And before that, there was some on mucosectomy and inflammatory lesions, and I don't think it's been described as a trigger for flare-ups.
Okay, but on the other hand, we do avoid periods when there's a very, very, very recent ulcer.
It's hard to say for sure in this case whether we've really reached the muscle or if it's more of an ulceration. I need to get back into diagnostic mode to put you back in LDI. We're not really sure. If we looked underneath, we might see muscle. In any case, there is definitely a loss of mucosal tissue and potentially submucosal as well. So at the very least, it's an ulceration, not just an erosion, and maybe even an ulcer that goes down to the muscle. Similarly here, it doesn't seem to be extremely deep, but still, there are a lot of inflammatory lesions. That's not the main issue we're dealing with here, but it's still an important point. And I haven't forgotten about my lesion, but I think it's moved down as I go further. It must be along my endoscope. Otherwise, I'll go back up to look for it, just to check before going all the way down if it's still there. I think I saw it move down behind me when we were closing up. Well, yes, you caught me there, so we're going to move it down. That was today's goal, to resect this lesion. But no, here's the piece we resected. You can see we went too far, despite the precautions we took. The muscularis mucosae and the submucosa are so thick that we still went a bit too deep during the dissection, probably because I didn't work my assistant enough. Again, these inflammatory lesions are a bit unusual. It's so thick that you can get caught out. The submucosa is not at all easy to distend and stretch, so sometimes you end up with a mucosal and submucosal layer that's much thicker than usual.
Okay, very good. See you next time.